Hello everyone, today we will explain hemophilia, which is an X-linked genetic disorder. And because of that, in cases of girl, we need 2X to be having the disease, while in cases of boy, 1X it be enough for them to be affected. So boys are way more affected than girl, except in condition like Turner syndrome, the girl having an XO, so an X will be enough for them to get the disease. Okay, hemophilia is having two types. Type 1 is type A and type 2 is type B. Type 1 is way more common than type B, although both are rare, because type 1 is actually occurring in 1 in each 5,000 normal newborn, while type B is 1 to each 24,000 newborn. And the defect in the type A is factor 8 deficiency, while defect in B is factor 9 deficiency. And both these factors are related to intrinsic pathway. We have an intrinsic pathway and extrinsic pathway. Extrinsic pathway is BT. And both BT and BTT share the common pathway. Okay, so the presentation actually depends on the stage of, depend on the age. In neonatal period, although it's rare, but if they are come and their presentation will be as an intracerebral hemorrhage. That's quite common for this neonatal period, although it's very rare to come. While the usual presentation age is toddler age, and the presentation commonly are bleeding into ankles, into elbows, okay? Then after that, it will be the knees and shoulder. The severity actually depends on the amount of deficiency. So if there is less than 1% factor activity, then the presentation will be very severe. Okay, while in case of there is less than 5%, there will be a moderate. More than 5%, it will be mild presentation. They will not come in toddler age, they will likely come into adult. Not adult, but let's say adolescent. The treatment actually is way more different than previous, because previously they had to collect 100 or 1,000 specimens of donors' plasma and give it to these patients. And because of that, there will be 100 of people or 1,000 of people dies because of transmission of virus like hepatitis B, hepatitis C. These are the older form of factor 8 and factor 9 given. But now there is a recombinant factor 8 and factor 9 with purified plasma, and they are given in case of acute bleeding until the wound is healed. There will be another drug, which is emicizumab, is a subcutaneous bispecific treatment and could be given not daily, it could be actually given monthly. So less doses, so more tolerance for the patient. For in cases of patient having hemophilia A and with mild presentation, so the treatment of choice in case of after we experience the response, okay, we give a trial of desmopressin. If there is a good response, then we will continue for desmopressin for that patient and consider the treatment of choice for him or her. Another problem that face us during that could be the inhibitors. Sometimes the body form IgG antibodies. These antibodies actually consider these factors that given as a foreign protein. So they will try to clear it from the body so the body do not use it, and will result in rapid activation and activation in these factors. So in that case, if the antibodies are in low titers and the patient have acute bleeding, we give him the factor either concentrated or in continuous infusion. But if we have high titer IgG antibody, then actually we need to give specific treatment that bypass this inhibitor, and it could include recombinant factor 7A. As we say, the complication is related to older form. Now, recombinant form are not related to this complication. And that is hemophilia A and B in simple way. Thank you.